Hi all, today we are going to see about antiplatelet drugs. Before going into antiplatelet drugs, today we'll see hemostasis, which is otherwise known as arrest of blood loss and blood coagulation, which involves complex reactions between the injured vessel wall, platelets and coagulation factors. Now we'll see about coagulation cascade. The clotting system consists of a cascade of proteolytic enzymes and cofactors. The inactive precursors are activated in the series, each giving rise to more of the next. The last enzyme, thrombin, derived from prothrombin, converts a soluble fibrinogen 1 into an insoluble meshwork of fibrin in which the blood cells are trapped to form a clot. So there are two limbs in the cascade, which is in vivo pathway, which is extrinsic pathway, and the contact or the intrinsic pathway. Both pathways result in activation of factor 10 to 10A, which converts prothrombin to thrombin. The calcium ions and a negatively charged phospholipid are essential for these three steps, namely the actions of factor 9A on 10, factor 7A on 10, and factor 10A on 2. So the phospholipid is provided by the activated platelets adhering to the damaged vessel. Now we'll see about the major components of hemostasis. So as the diagram says, it can be divided into two stages, the primary hemostasis and secondary hemostasis. In the primary hemostasis, there are again three steps: platelet adhesion, platelet release, and platelet aggregation. So we'll see detailedly about primary hemostasis. So in the primary hemostasis, there again include platelet adhesion, in which the platelets adhere to the collagen in the subendothelium due to the presence of a receptor in the platelet surface, which is known as glycoprotein, that is GP1A and 2A, which is an integrin. The adhesion to the vessel wall is further stabilized by von Willebrand factor and adhesion glycoprotein. This is achieved by the formation of a link between von Willebrand factor and other platelet receptor GP1B10 complex. So, in the next step, that is platelet release, after the adhesion, the platelets become activated and release three types of granules in the cytoplasm. That is dense granules, alpha granules, and lysosomal vesicles. Important products released from these granules are ADP, ATP, calcium, serotonin, platelet factor 4, factor 5, factor 8, thrombospondin, platelet-derived growth factor, von Willebrand factor, fibronectin, fibrinogen, plasminogen activator inhibitor, and thromboxane A2. In the last step, that is platelet aggregation, this process is mediated by the fibrinogen, which forms a bridge between adjacent platelets via glycoprotein receptors on platelets GP2B and 3A. This diagram gives us a summary about the platelet release. That is, after adhesion, it becomes activated and release three types of granules in the cytoplasm. As the diagram indicates, dense granules, alpha granules, chemokines, that is from lysosomal vesicles. So these will be coordinating the clotting function further. This shows the platelet activation by thromboxanes. So once the thromboxanes is being released, that is the generation of thromboxane A2 by the activated platelets, it will go through different pathways which involves various secondary messengers like IP3, DAG, and also an increase in cytosolic calcium concentration. It will in final effect the activation of GP2A and 2B and 3A receptors. This slide shows the sequential steps which happens in platelet adhesion to the collagen. So here in the injured vascular wall, the von Willebrand factor adheres to the subendothelial region and it binds to GP1B 5 and 10, and the rapidly formed bonds are quickly broken and also re-established, which causes the platelet to roll along the injured vessel. The rolling process slows down the platelets and it allows the platelet signaling receptors to bind to the collagen, which leads to a cascade of signals which is leading to the activation of GP2B and 3A, finally it will lead to the platelet aggregation. The upcoming diagrams shows the representation of whatever we have explained, how the platelet is binding to the glycoprotein, von Willebrand factor, and how the platelet gets aggregated after activation. So here you can see the platelet, the fibrinogen and the glycoprotein which has been linked with the collagen with the help of von Willebrand factor and how it causes platelet aggregation. The next step, which is secondary hemostasis, as shown in the previous diagram, it involves plasma coagulation system resulting in fibrin plug formation and takes place several minutes for completion. It can be defined as the formation of insoluble cross-linked fibrin by activated coagulation factor, especially thrombin. Fibrin monomers are cross-linked into insoluble strands to stabilize the loose platelet clot formed in the primary hemostasis. Now we'll see a summary about antiplatelet drugs, which is otherwise known as anti-aggregants. They are the drugs which decrease the platelet aggregation and thereby inhibit the thrombus formation. So they are effective in arterial circulation and are widely deployed in the prevention of thrombotic cardiovascular and cerebrovascular disease. So in the class of drugs, we can see 5 classes of drugs which are mainly COX inhibitors, phosphodiesterase inhibitors, ADP receptor antagonist, glycoprotein 2B, 3A receptor antagonist, and prostacyclins. This slide specifically tells about the mechanism of action of various antiplatelet drugs. To begin with, we'll start with aspirin. So aspirin, the mechanism of action is as follows. It acetylates and inhibits the enzymes COX-1 and thromboxane synthase by inactivating them irreversibly. Because thromboxane A2 is a major arachidonic acid product generated from platelets, and the platelets are exposed to aspirin in the portal circulation before it is deacetylated during the first pass in the liver, and because platelets cannot synthesize fresh enzyme, thromboxane A2 formation is suppressed at very low doses until fresh platelets are formed. Thus, aspirin-induced prolongation of bleeding time lasts for 5 to 7 days. The next drug we'll see about clopidogrel and ticlopidin. So it alters the surface receptors on the platelets and inhibit ADP as well as fibrinogen-induced platelet aggregation. The GI-coupled P2Y12, also we can be labeled as P2Y receptor. It's a type of purinergic receptors which mediate adenyl cyclase inhibition due to ADP are blocked irreversibly by the active metabolites of ticlopidin. As a result, activation of platelets is interfered. The fibrinogen binds to platelets is prevented without modification of the glycoprotein receptor. So there is no effect on platelet thromboxane A2, but the bleeding time is prolonged and platelet survival in the extracorporeal circulation is increased. So the next drug comes dipyridamole. It is as shown on the last slide, it is phosphodiesterase inhibitors. It inhibits phosphodiesterase as well as blocks the uptake of adenosine to increase the platelet CAMP, which in turn potentiates PGI2 and interferes with aggregation. The levels of thromboxane A2 or PGI2 are not altered, but the platelet survival time reduced by the disease is normalized. Then finally, the last class of drugs, which is glycoprotein antagonist. So these class of drugs are newer class of potent platelet aggregation inhibitors which act by blocking the key receptor involved in platelet aggregation, which is glycoprotein 2B and 3A. It's an adhesive receptor on platelet surface for fibrinogen and von Willebrand factor through which the agonists like collagen, thrombin, thromboxane A2, ADP, etc. finally induce platelet aggregation. Altogether, this will inhibit platelet aggregation. To end up with, we'll see the uses of antiplatelet drugs. So it has been widely used in peripheral vascular diseases, in venous thromboembolism, prosthetic heart valves and arteriovenous shunts, cerebrovascular diseases, coronary artery disease, and acute coronary syndrome. And here we end up the session on antiplatelet drugs. Thank you for listening.